Adam and I'm one of the improvement practitioners in the strategy team here at ESHT, and I'm in the Improvement Hub to welcome you to the first of our new QI mini modules. In these videos, what we're going to try to do is introduce you to some of the key concepts from quality improvement and explain how they might be able to help you to manage changes that are currently happening in your services and address some of the challenges that you might be currently encountering. So the concept that I want to introduce today is one of the most simple and powerful tools that we use in QI, which is called PDSA. PDSA stands for Plan, Do, Study, Act. The important thing to understand about PDSA is that it's a continuous cycle and not just a one-off intervention.
Let's start by looking at each stage in the PDSA cycle one by one. So we start with plan, which means we decide upon one idea which we'd like to test out to see if it results in improvement. And so we do it, but we test out this idea on a small scale, possibly with one patient or a small group of patients or for a small period of time. After doing that, we can study the results and look at some data to see whether it had a significant impact. And then we see if those results were helpful and if it's something that we want to adopt or whether we should abandon it. So let's say that we've tested our first idea and it resulted in a small improvement. So we adopt that change and that forms our first PDSA cycle. But we don't stop there, we continue to test further ideas, adopting those which result in an improvement to the area that we're trying to change. Over time, we hope to see that several of these small changes will add together to result in a significant improvement. Using PDSA means that we've gathered lots of data on all of the things that work and don't before we make any big decisions, and all of the team have been brought together to work on the problem. Let's take a look at a real-world example to illustrate how this might work in practice, in this case baking bread. So we have a process where we mix the dry ingredients together, then we roll them into dough and knead them, and then we're going to place them in the oven for a certain amount of time to bake the bread. But if the result is not as high quality as we might like and it doesn't taste very nice, then we're going to have to adjust something in order to try and get a better outcome. I might, for example, decide that I think the bread needs more salt, and that's going to be the first thing that I'll test to see if it improves the outcome. So now I'm going to go through the whole process again, implementing the change that I've decided upon, which is adding more salt. But perhaps it tastes better as a result, but there's another problem because the bread hasn't risen properly. So now I'm going to look at each stage of the process, thinking about what I might be able to change, the kneading, the temperature, and the ingredients. But the key difference that's going to turn this into a PDSA cycle is that I will test my changes to each part of the process one by one to see which ones make a positive difference. So now I've discovered the best approach to take at each stage of the process, and by doing so systematically, I've improved the quality of the loaf of bread as much as I can. Taking this approach to find the best recipe for bread might seem quite intuitive, even obvious. But what's interesting is we find that in organisations quite often we don't take this kind of approach. Actually, what often happens in organisations is that we quickly decide what needs to be done and move straight into doing it, often not taking the time to follow up and check what the outcome was or making changes based on those observations. In the PDSA approach, we take slightly more time in planning and thinking about different ideas that might help. And then after we've implemented them, we look more closely at what worked and what didn't and whether we want to adopt things. This means that when we move on to making decisions about what to roll out at scale, we're better informed. As a result, we're likely to encounter fewer problems and might actually save time overall.
So here's one I made earlier, perfectly baked thanks to several previous cycles of PDSA. But now let's have a look at some real-world examples currently happening within our trust.
Pre-COVID, when you were working on quality improvement, what was the aim at that point?
Well, the main problem is that we felt the existing ESD service was underused. Now, we were underperforming nationally on our ESD referrals, which is important for that to be high because the implication of that would represent that people were able to come out of hospital and have their therapy at home. So really, there was two stages to the project, and the first stage was to see what we could do internally. So what we could sort of change in terms of how we could make the process smoother. So we looked at the sort of barriers. We did a PDSA model in terms of the community teams in reaching into the acute to get to know the patients better and to see if there was any ways that we could manage patients differently, and that did have initial effects. And then we saw a good upturn in terms of increased figures on ESD. But the real change was we looked as to what we were doing, what was the criteria for ESD to enable the appropriate access to the ESD service. And as long as we could be responsive and that we could see that patient within 24 hours of their discharge, that would qualify a patient as ESD. So we were really looked at how we could restructure our service to be more responsive.
What kind of stuff did you do to restructure the service?
We also looked at streamlining paperwork and processes so that we could increase capacity. So we introduced a number of assessment tools so that we could measure acuity, dependency, and rehab complexity. So we could decide much more scientifically and objectively where a patient would best sit in their rehab after leaving the hospital. So we would do things, even on a daily basis. Did that work? And we would be always looking at the results. Were we getting more patients? So things were being changed, every few days to every week in terms of the thing that really made a difference. So it wasn't all at once. It was very much a PDSA model. At the end of the project, it was our ESD figures went up past our stretch target and above the national average.
So I'm just trying to think about whether the stuff that you did prior to COVID was helpful when you went into COVID.
Yep, all of that really, really important, because what we needed to do, to enable to increase our ESD targets, we have to have an increased capacity, which we've done. The risk stratification, which is using the measures to understand how ill people are, what level of rehab they need, and how severe their stroke is, was crucial in terms of being able to make sure those patients could go home or go to BIU and come away from the hospital. That tool helps you determine where someone could be.
I hope you can see now that you probably used PDSA many times previously without even realising it. The only difference in quality improvement is that we give things a formal structure and measure everything more carefully. So I hope you've enjoyed this video. Over the coming months, we're going to be putting out more of these mini modules covering various quality improvement topics and looking at some other pieces of work going on around the Trust where people have implemented QI to tackle some of the problems that they're currently facing. If there's any subject that you would like for us to cover, or you have any kind of feedback about this video, please get in touch with us at our team email address, which is going to be shown on the screen now.